Good morning, everyone. Thank you, Richard. So I'm going to begin with a case, some disclosures of mine, and in particular, the disclosure about being a consultant for Aranex is relevant to this presentation. I'm going to be presenting some work that I'm doing with them a little bit later in the talk. So here's the case. This is a 76-year-old woman who had surgery with me 4 years previously and did very well, and then presented with some new right forehead pressure. And you can see here she has this obstructed Agar-Nazi cell that's related to her symptoms. And she did not want to go back to the operating for this. So we discussed some of her options, and we decided to take care of this in the office. So here, can you see if that video can run? It was meant to run automatically. But what you're seeing here is an injection of the lateral nasal wall with Lidocaine, and this is done awake in the office. Should I go back? All right, maybe I can just jump ahead. The point of this video was to show the procedure, but also I had a conversation with the patient. And as a 76-year-old, this is after the procedure, and she's describing her satisfaction with the procedure, that she didn't have to go back to the operating room, and how she tolerated the procedure well, and that she had concerns about her own health at that age tolerating procedures in the operating room. So we were able to manage this patient successfully in a clinic setting with a procedure that had very little associated morbidity, and she was discharged basically within 15 minutes after concluding the procedure. So we'll talk a little bit as an introduction to office rhinology in the sense of the fact that post-operative care is really where a lot of the office rhinology procedures begin, and those are very critical to getting good outcomes after sinus surgery. And as you become comfortable with anesthetizing your patients and managing them in a more interventional way, then you can increase the complexity of the procedures that you offer your patients. And it is associated with a high degree of patient satisfaction. So I'm going to start with office-based post-operative care. We'll talk a little bit about how that transitions to more formal standalone procedures in the office, and then finally some new technologies to facilitate office care. I will have to describe these videos to you because they're all supposed to run automatically. But this is basically just a simple cleaning after surgery. And we have to ask the question, does debridement matter? And I think that just simply pulling out clots probably is not important in terms of achieving important outcomes. But there are some cases where debridement, I do believe, is critical to successful outcomes. And if you look at what the literature shows, these systematic reviews have mixed results in terms of the conclusions about the importance of debridement. So here we have a positive recommendation for debridement post-op, and this one says no recommendation for debridement. So a mixed picture. Cases like this, where you have some adhesions here, I don't think these actually affect the final outcome of a patient. And being aggressive about debriding these types of adhesions is probably not very important. However, you have a case like this, where you have the adhesion between the middle turbinate and the lateral nasal wall, and you have ossification of that lateralized turbinate, obstruction of the frontal sinus, development of a mucocele. And in this case, at some point, I think this was probably a reversible complication. And at some point, the post-operative care here probably lapsed and led to this later complication. So I would say this is a critical adhesion. And our goal in managing patients post-operatively is to try to avoid the progression of an early adhesion to becoming something like a critical adhesion. So here are 4 I's for managing patients and preventing post-operative scarring in the office. want to improve our office instrumentation, identify signs of unfavorable healing. We need to invest the time in taking care of these patients, and we need to intervene early. So first of all, if we're going to be taking care of patients after surgery, our equipment in the office should replicate what we have in the operating room. Now, it doesn't have to be the full extent of instruments, but if you do frontal sinus surgery and have no ways of manipulating the frontal sinus after your procedure, all you can really do is watch your frontal sinus close down or develop scarring, and you have no way to influence that outcome. So you should have a set of frontal instruments if you do a lot of frontal surgery. Through cutting instruments, these are just some examples of the instruments we have in our set, and we have a whole tray of instruments that we use. We have a microdebrider in our office as well, and you can see some of the examples of the instruments that we have access to, which really allows us to do a lot of procedures in the office. Second, identify signs of poor healing. So this is a fairly fresh post-op case. This is the sphenoid sinus, and one way to manage this is just to suction that mucus out and say, well, there's a little bit of pooling in the sphenoid sinus. But what you could also do is try to ask yourself why that is. Why is that sphenoid sinus accumulating mucus? And this may be part of the problem right here, and we'll talk about how we address that in a little bit. The third I is to invest time. And unfortunately, we have to face the fact that when we want to take care of complex care in the office, it does take time. So a lot of these patients can't be managed in a 10 or 15 minute visit. These patients need to be anesthetized. There are some complexities to that care. And so I will often schedule these patients outside of the routine office schedule to accommodate them. So part of the investment of time includes getting good anesthesia. So for routine post-operative debridements, we don't need to use any injections, but some patients are very sensitive, or patients in whom we're going to be taking down a lot of scar tissue. We will use a lateral nasal wall injection. Occasionally, we'll do a greater palatine block in the office, which is reasonably well tolerated. And that's mostly for posterior work in the posterior ethmoid or sphenoid regions. And then intervene early. So we like to divide the scar tissue before it matures. And again, we want to avoid the progression of a benign adhesion to a critical adhesion. So this is that case that I showed. And what we did was basically took some time. Are we going to get any videos on this, Richard?
Not on yours,
no. Oh, okay.
Unless you want to change, do you want to put your computer on?
I mean, I think we could.
Okay.
If, you know, I didn't realize that it hadn't been.
I'm sorry, I mean, there's playing in the back. There's some playing on the computer in the back.
Okay. Is that okay? Do we have time?
Yeah, let's take the time.
I mean, there's enough material. Oh, I don't have the app.
What do you need? What do you need for the adapters? I have it.
Apologize.
It's worth taking the time to try. You're trying to I'm trying to hear you. Do you want to use it up here for the computer? So while Professor Hwang is setting up, I just want to make sure you see the videos. How many people maybe are doing, let me ask this. How many people are doing a procedure that you would normally do in the operating room, or in the past have done in the operating room, are now doing it in your office? Okay, so about a third of us. Okay.
It's on mini display.
And those of you who are doing that, can I just ask you what country you're from? Saudi Arabia.
Okay.
Poland?
Finland.
I'm sorry?
Finland.
Finland.
Philippines.
Philippines.
Netherlands.
Netherlands. Here, okay, England, okay.
Romania.
Romania, okay. So multiple different countries, multiple different health systems. Was it, maybe again, you can just kind of shout out answers, was it easy to start? Was it hard to start doing that? What kind of barriers did you run into?
It's just, I mean, hospital
go through liquidation, but can be done. It's solved easily.
Okay, so the hospital holds the accreditation
That's
for the
worried
office?
about infection and sterilization. That's the only thing.
Okay. So some challenges with sterilization and infection control. Okay.
Well, I think you simply increase your performance by doing smaller things, and you see that places are doing well. So you're increasing your therapy also, especially with older people, which are very easy to handle.
So if I can maybe summarize what you said, it's kind of starting small.
Yes.
That worked. I can do that. I'll do a little more aggressive procedure, a little more aggressive. And I think you'll see that in Dr. Delgado's presentation. And so that's been my experience as well. And then you're saying that you're really doing it in older people that you prefer to keep out of the operating room from a general anesthetic. Okay.
I'm good, Richard.
You're ready. I can keep stalling.
You can go on. It may be more interesting, actually, than what I have to say. So,
We'll get the rest of the comments later.
okay, so this is that case. And so here, the issue is this early scar band here that's causing recirculation. You can actually see that mucus recirculating within the sphenoid. And so what happened was the portion of that superior turbinate was resected. There's the ostium, and you have this little bridge right here. So this is just, a 2-minute intervention with a straight through cut Blakesley. This is topical anesthesia. And I think if we did not do this, we would have a continued problem with sphenoid drainage. And this was identified at the first or second post-operative visit. Reconnect the sphenoid ostium to the surgical sphenoidotomy, and we've solved that problem. What about lateralized middle turbinates? I mean, I will be frustrated sometimes with these turbinates. I keep moving over and over. And what I will do if a turbinate seems to be terminally lateralized after the second or third visit, I'll just resect that leading edge of that middle turbinate, because I find that the rest of the posterior part of that turbinate actually is fine. It's just that leading edge. We resect that first 3 or 4 millimeters after local injection of a local anesthetic, and you can resolve the issue of the lateralized middle turbinate before it becomes a real problem and starts obstructing sinuses. This is a case of a revision maxillary antrostomy that we did in the office. And this is a patient with nasopharyngeal carcinoma. We did bilateral FES on. You can see on the left side, this is 3 weeks post-op, there's a patent but somewhat narrow maxillary antrostomy. But on the right side, and we had an antrostomy there at the first post-op visit, week 1. This is week 3, and it's basically closed down. So I brought this patient back on a separate day because I knew that I couldn't manage this within the 10-minute visit. But we brought all of our instruments out that were going to be required to restore the patency of this antrostomy. Otherwise, we'd need to return to the operating room. We used a lateral nasal wall injection. I had microdebriders, backbiters, and you can see how much scarring there is in here. This is all scar. This is not retained uncinate. This is scar that's developed, and probably because the patient was predisposed given his history of radiation. But we're taking this down in the office. We're not using any sedation. And you can see all of the scar accumulation within just 2 weeks since the previous visit. Now we're introducing the microdebrider to take down additional scarring. And the goal is to restore patency of the antrostomy and continuity of the antrostomy with the natural ostium, which we had found at the time of surgery. Here we're completing the procedure by just removing as much scar as we can that's built up circumferentially within the antrum. And this is the eventual outcome. So we're able to save that antrostomy by intervening at an early stage. And if we had just waited or hoped or maybe given the patient oral steroids, I'm quite sure that we would just be at a situation where we would have to go back to surgery to formally open that maxillary antrostomy. This is a more subtle case. This is a patient who had issues well beyond her immediate post-op healing period. She seemed like she had healed very well, but she was describing continued postnasal discharge. And I'll always look, if I can't identify the cause for the complaint, we'll just continue to look. And in this case, what we found was recirculation. But the recirculation was in a somewhat unexpected place. This is the middle turbinate that was preserved in surgery, and you can see the recirculation of mucus around an intentionally preserved middle turbinate. Because we identified that at this time, we offered her a procedure to resolve that area of recirculation. And we wouldn't have anticipated this because I felt like we left enough basal lamella, but the fact was that she was recirculating around that. So this was easily resolved by a local anesthesia, just bisecting the turbinate and separating the portions of that turbinate here and just a little bit of a silver nitrate cautery. And of course, we would not want to be too aggressive resecting this inferior posterior portion of the turbinate because of the potential arterial blood supply. But this patient did very well with that, and that resolved her issue of persistent postnasal discharge. And it wasn't an infectious issue. This wasn't anything that would have been improved by antibiotics or steroids. This was simply a mechanical issue. So the 4 I's will lead you to optimized post-FES outcomes. So if we are then comfortable with post-operative care and fairly aggressive post-operative care, this is what then we can then use as a stepping stone to more advanced standalone procedures. And in my experience, my patients are very satisfied with the opportunity to have these procedures done in the office, as I showed you with that first case. And what I find is that the patients tend to self-select. So there are some patients where we start in a nasal endoscopy and they're just like this and they're constantly moving, and those are not the patients that you want to try to convince to do an office procedure. It's just not going to work. You're not going to be happy, the patient's not going to be happy. But there are patients that will voluntarily ask you if there's any alternative to going back to the operating room. These patients are highly motivated. They tend to be very relaxed, so discussing a procedure like that does not cause them anxiety. And so they self-select, and I think that's part of how we find the right patients for these types of procedures. And so just was alluded to in the discussion, start with basic procedures, work to more advanced procedures. I do them without any sedation, and we just use the careful anesthesia protocols. And I think Dr. Delgado is going to talk about these procedures. I'm not talking about them, but I just wanted to make this transition from just post-operative care to what can be done in the office as standalone procedures. These are the things that we'll do in my office, and these are the various indications for office-based surgery. What I did want to just touch on in the end to conclude is some of the new technologies that are available that help us expand our offerings to patients. So first of all, there is now navigation that's available for the office. So this very similar setup that we would use in the operating room is now available in an ambulatory setting, and we pair this with an in-office CT scan. So we have a scanner in our office that is a cone beam scanner, so the patients can have complete point of care where they get their scan first and then they can come down and have their procedure. With our scanner, we get very nice quality images here. This is on the cone beam scanner, and you can pick up subtle things like bone loss here. This actually turned out to be a maxillary sinus lymphoma. But you see the bone details not sacrificed despite lower dosimetry. So these cone beam scanners have about 80% less radiation dosage than the standard CT scan. And so you can see how the scanner or the navigation is set up in the office, and it's well tolerated by the patient. Stereo-eluting stents are another technology that's now recently become available. This is the Sinuva device that was just released by the Intersect company, and this delivers mometasone over 90 days. It's an absorbable stent. It's placed in the office. We have some good evidence that this is helpful for patients, and specifically for patients with recurrent nasal polyps who may be considered candidates for returning to the operating room. This was a study from 2016, and a more recent study was just published, the results of a phase 3 trial. And these studies indicate a significant reduction in the polyp grade for these patients who received this device in the office. And because we're just having real-world experience with this, because it's just released, I don't have personal experience that I can share with you for this, but there are some very well-structured studies that were run by the Intersect company that support its use. And then lastly, a little bit about cryotherapy. This is something that I've been involved with in a consulting way. For patients with allergic and non-allergic rhinitis, we certainly recognize the disease burden, but we've had very little to offer our patients at this point from a surgical standpoint. We usually consider this a medical disease. There is videoneurectomy that's been described, and at least in the States, this is not widely used. And posterior nasal neurectomy, very popular in Asia, and becoming more popular in other parts of the world, targeting this nerve, the posterior nasal nerve, which is a postganglionic portion of the parasympathetic supply to the nasal cavity. But it's still a surgical procedure, and a lot of patients with rhinitis aren't prepared to have a general anesthesia for rhinitis. So cryotherapy has been used. It's been described. This has been described as early as in the 1970s. But at that time, it was not an endoscopic procedure. The cryoprobes were very bulky, and you had to bring in a big tank of a cryogen reservoir. So there really wasn't a lot of precision to this approach. But this new device by the Aranex Corporation is called the Clair Fix, and what this does is delivers a little bit of cryogen from a reservoir here with nitrous oxide to this tip, and this little paddle will then freeze the tissue that it's adjacent to. So it's a 1-minute freeze, and the advantage of cryotherapy is that it has a very predictable zone of tissue ablation. So because arteries are warm, they're not actually ablated by the freezing. So you don't actually get a lot of necrosis, but it's enough to freeze the nerves. And so it's done under local anesthesia in the office, about 1 minute of treatment per side. This is a demonstration of the technology. So the posterior nasal nerve emerges from the sphenopalatine foramen. So you're going to be focused on this posterior area of the middle meatus. And this is the device being placed, and it's being placed into the posterior of the middle meatus. And you can see the paddle here. And what you'll see is when the cryogen is deployed, you're going to literally see ice crystals form in that area. And then the timer is set to 1 minute. And so here you can see the ice crystals are forming. And the patient is awake for this, and with good anesthesia, the patients really don't feel very much of this. And then after the conclusion of the freezing, the patient breathes through their nose to kind of warm those ice crystals. It's defrosted, and then the device is then removed. And that's the conclusion of the procedure. So what it looks like post-op here, immediately post-op you get this little zone of freezing right here, you can see that. But at 30 days and at 90 days you can see that that tissue heals very well. So the outcomes are promising. This is an early study published last year where the total nasal symptom score was used as a measure of symptom outcome, and you can see improvement at 30 days. And even though there was a fair bit of loss to follow-up, even at 365 days, the people that were able to be followed that far still showed some improvements in their rhinitis. So some promising data. This is dividing them into allergic and non-allergic patients, and it does appear that both groups benefit, but this is hopefully will be borne out in a more extensive phase 2 study that's currently underway. So in summary, for this introduction to office-based rhinology, office-based rhinology certainly at the very minimum is important for achieving good post-ESS outcomes, and it's associated with a high degree of patient satisfaction. Thank you.